Okay, well, why don't we go ahead and kick off our afternoon's events with the lecture I know everybody has been waiting for today. It's my pleasure to introduce somebody who is not the former Attorney General of the United States, but is one of our most distinguished physician scientists and public health administrators in the history of the United States, with an extensive track record of leadership, research, and community engagement. He's a graduate of Morehouse College and holds MD and Ph.D. degrees from Case Western Reserve University in Cleveland, Ohio. Council Patton, I said that just for your benefit. He served as the 16th Surgeon General of the United States and 10th Assistant Secretary for Health and Human Services. He also served as the Director of the Centers for Disease Control, otherwise known as the CDC. He has also held top leadership positions at our institution as Interim Dean for our Postgraduate Medical School and President of Meharry Medical College, as well as Professor and Chair of the Department of Community Medicine and Family Practice at the Morehouse School of Medicine. Currently, he is the Founding Director and Senior Advisor for the Satcher Health Leadership Institute at the Morehouse School of Medicine in Atlanta, Georgia. So guests, students, faculty, audience members, it is my great pleasure to introduce Dr. David Satcher.
Well, thank you very much, President Carlisle, for the very kind introduction to Dr. Friedman and this great team of researchers and students. I'm delighted to be here. I'm not sure that I'm on the right stage because I haven't been in the laboratory recently, but I certainly appreciate people who ask tough questions and then organize strategies for answering them. And so I told the students at our meeting at lunch that they are very fortunate to have the opportunity to work with people in laboratories like Dr. Friedman and others. It's a tremendous opportunity that will benefit you for many, many years to come. I promised that I would only tell one story from my early days at Drew. I had a great experience here from 1972 to 1979. And it was the kind of experience where one thing led to the other. I came to spend 2 years here as a Macy faculty fellow and ended up spending 7 years and getting into leadership roles that I actually didn't plan. But one story that comes to mind now, since I understand that Dr. Sherman Mellencamp just passed recently, and it reminded me of all of the time that I spent with him when I was interim dean debating about the UCLA-Drew relationship. It was a tough time for that relationship. Our founding dean, Dr. Mitchell Spellman, had left to go to Harvard as associate clinical dean because he basically had given up on this idea. And so I had just become a new chair of family medicine, and all of the chairs got together to have a meeting to decide what we were going to do. And you know, I was the youngest, the newest, so I had a meeting downtown, and I felt comfortable leaving the meeting because I felt they'll take care of it. I mean, they know much more than I do. And what they did, of course, was to vote to ask me to be the interim dean and CEO. And not only that, they called my wife and told her how great an opportunity this would be for me. So when I got home, she was pushing the idea. But Dr. Mellencamp was known for his stories. He loved to tell stories, and whenever we would be having discussions and I would be talking about the importance of the Drew mission and why UCLA, you know, needed this partnership, he would, sometimes the discussion would really get heated. And he would always calm me down by telling a story. And one of the stories that I remember was the day when I was there in we were having this discussion about the value of for medicine in this country, and he was talking about the fact that he wasn't convinced that people were carrying out these missions. I got a little upset, so he said, David, let me tell you a story. He said, there was a student here at UCLA, a medical student, and all during his years here, he just talked about how sad it was that we weren't doing more for underserved communities. And he was really upset about that, and he told us what he was going to do when he graduated. So he did graduate, and a few years later, the dean was going through a folder, and he wanted to know what was happening to their graduates, and he spotted this student. And so he told his staff that he wanted to visit his office. He had no idea where the office was. So they looked it up, and they found that this doctor was practicing psychiatry in Beverly Hills. And you know, the dean thought, how in the world could this guy be practicing in Beverly Hills? They have too many psychiatrists. But he said, okay, I won't take anything for granted, so he decided to go visit him anyway. So he went out to his office, and he walked in the door, and there was a sign. It said, if you love your mother, go to the right. If you hate your mother, go to the left. Well, the dean had nothing against his mother, so, you know, he went to the right. Then he walked down the hall a few yards, and there was another sign. It said, if you are suffering from anxiety, go to the left. If it's depression, go to the right. Well, he was a dean, so it was easy. He went to the anxiety one. He kept walking, and he got further down the hall, and it said, if your salary is $250,000 above, go to the right. If it's less, go to the left. So he went to the left, and he found himself right back out on the street. That was Sherman Mellencamp. So if you never met him, that's the name. And I guess he lived to be almost 100, didn't he? Yeah. Well, I want to talk about confronting substance misuse and abuse and the implication of the Mental Health Parity and Addiction Equity Act. As most of you know, for the last several years, I have been involved with health policy and public health. And so this is sort of the slant that I bring to this discussion. I don't plan to talk about any specific drugs, and I say that because just about every time I do a presentation, and this works sometimes and sometimes it doesn't, but every time I do a presentation, I include a disclosure form. Okay, and I didn't necessarily think, okay, but this was my disclosure form. I did include it here because I at least wanted you to know. And American Program Bureau, I think as I was telling somebody, is just an organization that helps to help busy speakers to schedule and plan presentations, not the content, but travel and all of that. But I want to say a word about the Satcher Health Leadership Institute at the Morehouse School of Medicine, which we started 10 years ago. So we're celebrating our 10th anniversary. And by the way, it's interesting how it started because when I left government, I went back to Morehouse. Dr. Gavin went back as president. I knew I didn't want to be president, so I had said no to that. So I went back to start the National Center for Primary Care. And things were going on quite well, and 2 years later, Dr. Gavin told me and said, Dave, I'm leaving. And I won't go into all the battles he was having, but he left. And then I got a phone call from the board saying that they needed me to take over on an interim. And I had practiced saying no, so I said no. But then the faculty came and they said if I didn't do this, many of them were going to leave. So I agreed to serve for 6 months and served for about 2 years. But during that time, we had a lot of discussions about leadership. And we read the best books on leadership. So when we recruited a new president, the board voted to establish the Satcher Health Leadership Institute. And our mission is about health equity, really. It's about helping to prepare leaders who will help to eliminate disparities in health and certainly work toward health equity. This year at the NMA, which just ended, we had a 1-mile walk with children. It's interesting because that started 10 years ago when the NMA met in Atlanta, and this is the picture from that walk. Shirley Franklin was the mayor of Atlanta then. We believe, of course, whether you're talking about substance abuse or access to care, the need for leaders is too great to leave their emergence to chance alone. That's something that we believe very deeply. That was stated by the Institute of Medicine in a report in 1988 dealing with the future of mental health. As Surgeon General, I had the opportunity to release several reports, and one of the areas where there had never been a Surgeon General's report was in mental health. And so I became Surgeon General in February of 1998, and I believe it was December of 1999, we released the first ever Surgeon General's report on mental health. And there were several to follow, you know. And as you see, we also did the first report on overweight and obesity and 3 reports on smoking. The one thing I will say about this whole relationship between the Office of the Surgeon General and smoking is that it has probably been the area where the Surgeon General's office has had the greatest impact. From 1871 to 1954, the Surgeon General was head of the Public Health Service. It was a very busy position, but in 1954, during the Eisenhower administration, there was a Secretary of Health, Education, and Welfare appointed, and that person became head of the Public Health Service technically. And the Surgeon General's role changed. Some people thought it was diminished. I think it was the change that led to the Surgeon General being recognized by the American people. There had never been a report from the Surgeon General before 1964, and that was a report on smoking and health by Dr. Luther Terry. And when you think about public health successes, I don't think there's been a greater one than, I think you heard some of this from Dr. Compton this morning about what's happened to smoking in this country. When the report on smoking and health was first released, over 40%, almost 45% of the American people were smokers, including 33% of women, and smoking was lower in women. And today it's down to less than 15%. We estimate that over 10 million lives have been saved. Over 10 million lives have been saved because of that report. And even though there are still far too many smokers in this country, and every time there's a new report, we look at all the new diseases that we can now associate with smoking. So as you talk about substance abuse, I certainly agree with whoever it was who said smoking is one of the most serious. Nicotine is one of the most addicting drugs known to man. So I think that intervention was important. But on a more important perhaps is that on a global basis, we've seen a dramatic decrease in smoking, even in developing countries. And it's going to save a lot of lives over time. So I think that's one of the most important reports from the Office of the Surgeon General. These are the other reports on mental health that we did. The big one, of course, was a report, mental health, a report of the Surgeon General. But we also did a report on children, treating children's mental health, a report on culture, race, and ethnicity that's probably gotten more attention than any of the reports. And then the final report that we did in February 2002, the report on mental retardation. These reports have, I think, had a tremendous impact on the way people think about mental health, because one of the problems, whether you talk about substance abuse or mental illness of some other kind, the whole issue of stigma is big when it comes to mental health. and it prevents people from seeking treatment, often until it's too late. I mean, we have people every day who are committing suicide who've never been diagnosed as depressed, never been treated. And so the stigma surrounding mental illness, whether it's a veteran from the Afghanistan or Iraq war, or a high school student, I mean, like the West Point graduate who was first in his class in just about everything, and 2 weeks later committed suicide without having ever been diagnosed as depressed, but he had been. So stigma is a critical issue. And I want you to think about substance abuse and substance misuse when you look at this definition of mental health. We debated this before we decided how to define mental health. We thought four areas were critical. Number one, this whole issue of how we perform and whether, in fact, we're able to perform in our work, whether it's being a student or working in the laboratory. One of the components of the definition of mental health is being able to be productive in your work. But it's also, and very importantly, your ability to relate to other people and to have positive relationships with other people. It's interesting, some people almost have to be high to relate to other people. So sometimes people abuse drugs because it allows them to function, when in essence they need treatment for a mental disorder. So the abuse of drugs is interestingly related to mental health. But fulfilling relationships with other people is part of being mentally healthy. Then the ability to adapt to change and to successfully cope with adversity. When Hurricane Katrina took place in New Orleans, NIH asked me to work to help reestablish the healthcare infrastructure there. And that not just New Orleans, but even in Baton Rouge. And what we decided to do, among other things, was do some screening. And one of the easiest things to screen for, of course, is depression. So we set up tents and things, and we screened for depression. And depression in New Orleans and Baton Rouge went from 10% of the population to 30% after Hurricane Katrina. And so having to adapt to that kind of change and to deal with that kind of adversity is a real test of mental health. And certainly it doesn't surprise me that somebody who goes to Iraq or Afghanistan is at a greater risk for post-traumatic stress disorder, even though it's very clear that not all of the people who suffer post-traumatic stress disorder after having served in Afghanistan and Iraq have necessarily been in combat. So there's a lot of questions about what is the etiology of an increased risk for post-traumatic stress disorder in this population. But drug abuse, of course, is a real issue in that population too. There were some key messages that I think are still very critical today. One was that mental health is fundamental to overall health and well-being. Nobody can take his or her mental health for granted. You can be mentally healthy today, of course, and mentally ill tomorrow, as we've seen after traumatic experiences. Mental disorders are real. There are still people, of course, who believe that mental disorders represent spiritual problems, and that people, and some of the churches, of course, preach that if you just have more faith, but mental disorders are real. They have chemical bases in the brain, for the most part, and mental disorders are disabling. As disabling as cancer or heart disease. The World Health Organization estimates that mental disorders are responsible for more disability-adjusted life days, or life years, than anything other than cancer. It's second only to cancer when it comes to disability-adjusted life years. And people with mental disorders have a life expectancy that's 25 years lower than the rest of the population. Now, so why would people with mental illness have a life expectancy that was so different from the rest of the population? Is it the mental illness that kills them? Well, yes and no. Clearly, people with mental disorders are more likely to smoke, more likely to be obese. Like the last figures I saw, about 44% of people with mental illness were obese, and certainly a large percentage of people with mental illness smoke. So these things that tend to go along with mental disorders certainly contribute to decrease in life expectancy. And mental disorders are common, and they are even more common than this. Mental disorders occur in probably 1 in 4. The most recent data would suggest, even though people go back and forth in the Harvard studies, Ron Kessler, but mental disorders affect about 1 in 4 Americans. And that number has certainly not been decreasing. But even if you say 1 in 5, you're still talking about almost 57 million Americans suffering from a mental disorder on any given day. And so, in any given year, I should say. The good news when it comes to mental disorders, just like with, I think, substance abuse and misuse, is that research, including the kind of research that you're doing here, has definitely improved our ability to recognize, diagnose, and treat conditions effectively. And it's probably the area where we're learning more. When it comes to the 10 leading causes of death in this country, I think we've probably invested, relatively speaking, less in the area of mental health. Certainly Alzheimer's is certainly one of the leading causes of death. We invest about $5.4 billion a year in research related to cancer, and now $4 billion a year in heart disease related research. We have, going into 4 years ago, President Obama's second term, we were investing about $540 million in research in Alzheimer's disease, for example, which is the fastest growing cause of death in the 10 leading causes of death. That's gone up to about $1 billion. Some of the things that President Obama has pushed, because many of us were pushing him, of course, in part, but clearly it's an area that needs a lot of work. Research on the brain generally needs a lot of work, and it's one of the best investments that we could make. But we've had trouble getting that same kind of enthusiasm that we were able to work up for cancer research, and it's paid off. And when we look at the progress that we've made with cancer and heart disease, we have seen a dramatic decline in death rates from both cancer and heart disease. And so we need to invest in research in mental health and in areas like Alzheimer's. Some people are hopeless in the face of mental disorders. And people don't talk a lot about treatment when it comes to substance abuse. I don't know if this has been discussed here today at all. I've been sort of in and out, but the crack cocaine epidemic in the 80s in this country was very interesting. It primarily affected minority communities. It resulted in mass incarceration. It was not dealt with as a medical problem, it was dealt with as a criminal problem, criminal justice problem. And so that approach to crack cocaine has led to a lot of people being incarcerated, mostly black men. And so when you see us really spending a lot of time with the opioid problem, some people respond by saying, well, I mean, that's discrimination, they didn't do that. I respond by saying, I think we've learned something, and hopefully it will mean that in the future, we will be much more sophisticated in how we deal with problems like this, and that we will see medical problems as medical problems. And yet I think we do owe something to those communities that have lost so much because of the way we approach cocaine, crack cocaine addiction. I don't have to tell you that crack cocaine made cocaine affordable to people in communities where it hadn't been before. So it became something that, especially in black communities, became a major problem. It led to a lot of crime, a lot of violence, including right here, of course, in this community where we are now. So I think hopefully we've learned a lot from that experience, and I'm very pleased that the Surgeon General, Vivek Murthy, is working on a report on drug addiction. I think it's overdue, and I think he's going to do a great job. I was with him recently at Meharry Medical College, where he outlined the approach to his report on opioid addiction. And so I think we have an opportunity to make some real progress in this area. We don't have to go back and relive the past. We just have to make sure that we learn from it. And so I'm hoping that that will be the situation here. Well, so that's the good news, that we do have the ability to treat and to make progress in dealing with mental disorders. The bad news, and it's getting a little better, but it's still bad news, of those with the diagnosis of mental disorders, fewer than half of adults. And what bothers me most is that fewer than a third of children get the help that they need. And that's why we did the report on treating children with mental disorders, because we felt that that area needed a lot of attention. The Affordable Care Act helps with that because it requires screening, including screening for mental disorders. And as Dr. Cummins, pointed out this morning, Compton pointed out this morning, I just think that we have some real opportunities here when it comes to being able to intervene on a timely basis. This is from the Substance Abuse and Mental Health Services Administration. In our report on mental health, we pointed out that based on preliminary data, clearly people with mental disorders had an increased risk of substance abuse. But this report from SAMHSA that came out 10 years after the Surgeon General's report clearly shows this association, an increased risk of substance abuse in people with mental disorders. Now, that's not being specific enough, and I'm hopefully the kind of research that's going on now will help us to be much more specific about how mental disorders, the many ways in which mental disorders can affect substance abuse. We certainly know that there is such a thing as self-medication, and that self-medication often leads to addiction. And that's true for smoking, and it's true for other forms of addiction. But I don't know, Key, I hope you can read that. It's in all of these areas, cocaine, marijuana, et cetera, there's a greater risk in people who have suffer mental disorders. So those data are pretty convincing today. And so there are a lot of implications to that. And again, it takes us back to childhood and the fact that if we can do a better job of diagnosing and treating children with mental disorders, we're going to have fewer problems with substance abuse. Dr. Compton mentioned the study, I believe it was Holmes and Olmsted, did a study showing when nurse practitioners visited with pregnant women, and then after they delivered, visited them at home for about 9 months, I believe, because I included that study in the Surgeon General's report on youth violence prevention. And so the other thing that study showed was that the children of the mothers who were visited by the nurse practitioner were 50% less likely to be engaged in violence by the time they were teenagers. That relationship and that interaction led not only to a decreased risk for drug abuse, but they are related, of course. And I know that even though things in this community are not as bad as they were when I was here in terms of violence, it's still a major problem. And the more we can do to address it, the better. But clearly, working with parents is important. In the Satcher Health Leadership Institute, in addition to our health policy program that we have for physicians and people with Ph.D.s in other areas of health, and now even JDs, in addition to that program, where we've graduated about 35 people, we have what we call Smart and Secure Children's Program that really focuses on how can we help parents to do a better job with children, especially between the ages of 0 and 5. And this is not one of those situations where we say we have the answers. What we're saying is that there's some real opportunities between 0 and 5 because of what we know about the brain and because of what we know about its stage of development. There's some real opportunities to help parents stimulate the growth of the brain and the development of it in the right direction. So in that program, we deal a lot with communication, early as possible communication. And that includes music and not just talking, but early as possible, but also nutrition and the avoidance of toxins. Those are all really critical components of that program. And we've had about 300 parents to go through it. NIH has recently funded us to replicate that program in 12 states, and we're already in 7 states. But I think whether they're single parents or dual-parent families, parents generally want to be the best parents they can be. And we have been very pleased with the reaction we've gotten from the community. And it's not just one parent, one child. These parents come from a community. And when they go back there and they're all committed to doing a better job in terms of child rearing, it affects the whole community. We have the same problem that I'm sure you do. Only 20% of our parents are fathers because of that problem, of course. But we've even been able to get some fathers to show more interest in their children with some guidance and to visit the schools, even if they're not willing to visit the homes. So there's some real opportunities here. And this is basically showing the same thing, that there is this increased risk of substance abuse in persons with mental disorders. And as time goes on, because of your research and others, we're going to be able to get much more specific about that. And the more specific that we're able to get, the better job we're going to be able to do in areas of prevention. And I mean, I have come to believe over the years, even though I enjoy one-on-one patient care, especially when I was out here when we had 300 sickle cell patients in our clinic. Can you imagine the family practice center taking care of most sickle cell patients? We did, and we even had phone by our beds, and we'd come in at night when a sickle cell patient came in crisis. And I don't have to talk about dealing with pain in sickle cell patients, and the fact that you're always dealing with the risk of substance abuse, the risk of addiction, and yet dealing with some very serious pain at the same time. So that was a challenging experience, but I think we're to the point now where we can make a difference in the lives. Now, Dr. Compton covered this, I think, quite well, but I want to just talk about why did the CDC do a report targeting primary care physicians about opioid addiction and treatment. Why? I mean, is that something that CDC usually does? Well, it certainly does reports on immunizations, but usually things that deal with epidemic infectious diseases. When I released the Surgeon General's report on overweight and obesity, I believe it was the first time that we referred to something other than infectious diseases as an epidemic. We said that overweight and obesity in this country was at epidemic proportions. And clearly, when you look at what's happening with opioid abuse, it is that epidemic proportion. And I think it was, if you remember the slides from Dr. Compton, the way those curves were going up, that's what led the CDC to feel that it was appropriate to get involved with this issue and to issue the guidelines. Now, their guidelines are extensive. It took up a whole MMWR to cover their guidelines, and they based it on pretty solid evidence from people who are involved in this area of research. But as you can see, between 2004 and 2013, a dramatic rise in opioid abuse and dependence, and even this study of fatal overdoses involving opioid analgesics. The first recommendation, and I recommend that you take a look at these CDC guidelines. The first one, of course, was questioning whether, we should use opioids to treat chronic pain. Didn't say we shouldn't, but questioning whether it was appropriate, and certainly shouldn't be the first move that we make because the risks are so great. So the question as to whether we should do that or whether we should begin by dealing with not just non-opioid, non-pharmacological strategies in general, but whether we should be dealing with cognitive behavioral change and those kinds of interventions. And so more and more now we're seeing that. And when we certainly know with chronic pain, and the most common chronic pain seems to be low back pain, that for many people, ultimately, the most effective intervention is going to be exercise-type intervention. And yet there will be times when people will have to be treated with drugs. And of course, when that's the case, it's certainly better to start with drugs other than opioids. That's basically the message, I think, from the CDC. They didn't say that we should never use opioids to treat chronic pain, but it should never be our first line of intervention, and we should proceed very cautiously if we're going to take that approach. And I just want to say that that's critical. The CDC doesn't get involved in these kinds of things unless it fears an epidemic. And all you have to do is look at the curves to see that we're facing an epidemic when it comes to a dramatic increase in the use and abuse of opioids in medicine, in primary care, because, again, they pointed out that most of these prescriptions are being written by primary care providers. Now, at our institute, a few years ago, we voluntarily took over mental health services at Grady Hospital. Grady Hospital is one of the largest public hospitals in the country, and we just felt that we could demonstrate that a better job could be done in dealing with mental health issues in the emergency room. Some of you know Dr. Linda Wren, who is a psychiatrist, and she came to us shortly after finishing the Robert Wood Johnson Clinical Scholarship Program at Penn. But this was her first project to really, for us to take over mental health services in Grady Hospital. Now, I can tell you what it was like, and I won't exaggerate, but patients coming to the emergency room with mental health emergencies at Grady were often waiting 12 hours before they were seen. That was the average And a lot of times that was because they had to wait for somebody to come in from the outside, a psychiatrist, if you will. And they were often restrained physically or chemically. They're in the emergency room in order just to control them until they were treated. And it was not a pretty picture. And recidivism, as you can imagine, was very high. When people were treated and sent out, you could bet that they were going to be back in a short period of time. So why in the world would we take over? It's sort of like asking me why I agreed to be interim dean. But we took over, we voluntarily took over mental health services in Grady. And we got some support from the state of Georgia. We convinced them that we had an idea. So what we did was to develop a team of people to work with mental health emergencies. Not just a psychiatrist, but primary care providers, psychiatric social workers, and all those who made up a team to deal with people coming into the emergency room for mental health emergencies. And the whole team was really trained to intervene at different stages. Sort of like Ron, I'm sure will remember when we opened the Family Practice Center here, we made a commitment that no patient would wait for more than 15 minutes without being seen. We lived up to that commitment because it meant that we had, education, people in education, nutritionists and others. And so by the time the patient had been there 15 minutes, people had started to interact with them. And they felt they were being seen, and they were. And so it made a big difference. So in the emergency room at Grady, we had a team of people that we used, and the integrated team, we called it. And now we're using that in community health centers throughout Atlanta. But that team of people reduced waiting time by 80%, reduced the use of restraints by at least 70%. And what Grady was most interested in, I think, was that we reduced costs by 40%. Cost reduction, and that's been published, by the way. So, and I'm only saying that because I think when it comes to dealing with substance abuse, when it comes to dealing with mental disorders, we do need a team approach. We need a team approach, and we need to have that team training together, understanding what the roles are, and implementing it when the patient shows up, or even if they're still at home and in the community. So we have now implemented integrated care for mental disorders in 11 community health centers around Atlanta. But I still think the impact on the emergency room and the fact that we are able to provide continuity of care for people that we encountered in the emergency room, but ended up connecting them to continuity of care in the community. So they had an ongoing relationship. We were talking about this last night or day before yesterday at the NMA, and it's really critical, I think, that you're not going to always have the psychiatrist there to see the patient, but the people who are treating the patient ought to be in contact with the highest level of care possible, however you define that. And so in our situation, we have people trained together, and we have them prepared to share information and make decisions jointly to make sure that patients get the best care that they can get. And obviously, a lot of those patients are dealing with drug abuse. But it's been a very interesting experience. And again, I think Dr. Confronting this morning certainly covered how people obtain these drugs. And as you can see, from a friend or relative, but that's often traced back to healthcare providers. So we have a big job on our hands in terms of getting to the bottom of this. I want to say a word about the Affordable Care Act, which I think has empowered us in many ways when it comes to dealing with mental health problems, even though Congress has not supported the implementation of the Affordable Care Act. We have 20 million more people covered by insurance than we did when the Affordable Care Act was passed. And so we've made a lot of progress, and yet we could be much further along if this had been something that was carried out in Congress as a bilateral action as opposed to one party. Now, having worked in Congress and with Congress, I know that's not easy. But I do know that I think there was a time in this country, and I would say when I was in office, when people really worked across the aisle. And that's what statesmen do. Whether it was a Child Health Insurance Act that was sponsored by Nancy Kassenbaum, I believe, on one side, and Bill Frisk, of course, and then Ted Kennedy and others. So people came together across aisles to do what was best for the American people, and that didn't happen with the ACA. And so it's going to take us a while to really realize the advantages of it. But the Affordable Care Act will expand mental health and substance use disorder benefits and parity protection for, at the time we said up to 62 million Americans. We didn't know, of course, at that time that so many states would refuse to expand Medicaid. That includes Georgia, by the way. So we're struggling at every level in terms of how politics are influencing action. I was in Idaho speaking recently. Idaho was the last state in the country that I had not visited. So I was there to speak at their health summit, and this issue came up, and the guy told me, he said, well, Dr. Satcher, we can't pass the expansion of Medicaid because the governor doesn't like Obama. I said, doesn't like Obama? What does that got to do with the health of the people in Idaho and all the people who could get insurance? So we're dealing with tough times when it comes to the way we relate to each other politically. And a lot of people are suffering, certainly in Georgia. Hundreds of thousands of people are being denied access to care because of that. And we have a pretty good governor in Georgia. Most health plans must now cover preventive services, which I really like, including depression screening for adults and behavioral assessment for children at no cost. And if anything on here could really make a tremendous difference, it would be the behavioral assessment for children. And that's a part of the Affordable Care Act. That's a part of what's supposed to be available at no additional cost, and that is critical. The earlier, as you've heard here today from Dr. Compton and others, the earlier we can identify mental disorders or challenges and begin to treat them, the less problems we're going to have in terms of mental disorders. There's no question about the fact that the earlier, the better. And I'm hoping that will become very obvious. Starting in 2014, and remember I did this slide in 2012, plans won't be able to deny coverage or charge more due to pre-existing health conditions. Now, one of those pre-existing health conditions that get a lot of people in trouble is when a child has been diagnosed with a mental disorder. And in the past, insurance companies have turned down people because of that pre-existing condition and others, and the damage that does to a family. I mean, so just that one thing alone, if you think about it, and the impact that could have, will have, in terms of improving how we deal with mental health and mental disorders, tremendous. So I think those are three things in the Affordable Care Act that a lot of people overlook. But I think that one specifically is for every family, not just families with mental disorders, but families with any kind of health problems that in the past insurance companies could use to refuse to insure you. Now I have to mention a couple of names here. The legislation that passed in 2008 was the Mental Health Parity and Addiction Equity Act. It was sponsored by two senators. One was Paul Wellstone from Minnesota, one of the most liberal senators in Congress. Some of you know he later died in that airplane crash about, I forget how many years ago. The other one was Pete Domenici from New Mexico, one of the most conservative senators in the Congress. Now the question is, why in the world did these two people find each other and agree to sponsor this legislation? Any ideas? Somebody in the family. Somebody in the family had, I think, I won't even try to remember specifically, but certainly Senator Domenici had a family member with a mental health problem, and so did Paul Wellstone. And so they were able to come together and sponsor this legislation. But the name I want to throw out there is Patrick Kennedy, because Patrick Kennedy had a lot of passion in pushing this. You know, it's easy for a Surgeon General to release a report and to call for parity of mental health services. But getting it through Congress, that's another issue. And Patrick Kennedy, who was elected to Congress at age 26, nephew of President Kennedy, who passed the Community Mental Health Act in 1963, and also son of Edward Ted Kennedy. So what is unique about the Kennedy family? A lot of things. They have been one of the most powerful families in the country, but they've also suffered greatly from mental disorders, right? It's been, and Patrick himself, now he's written about it. If you haven't read his book called A Common Struggle, Patrick himself has suffered from mental disorder. Patrick tells stories about going to the emergency room with low back pain and having a quick workup and then getting a prescription for opioids, in some cases for 1 month. I mean, he's a powerful person. And they never ask him about his family history. What happens in the emergency room? They never ask him about his own history of drug use and abuse. So when we prescribe medication for people without knowing their history, their family history, which is important, or their personal history with drugs, we are contributing to this epidemic, as the CDC calls it. But if you read Patrick Kennedy's book, A Common Struggle, he really, I think, outlines in a very positive way the way this is dealt with in our clinics and emergency rooms throughout the country. Well, at lunch over there with the students, we were talking about physical activity. We weren't talking about mental health, I don't guess, but we were. But I want you to know that the two are inseparable, that in dealing with anxiety and depression, and the studies were done at Duke a few years ago, showing that physical activity could be as effective as medication in treating depression. And obviously the ideal treatment is now a combination. But to treat a patient with depression without including physical activity is really, should almost be malpractice. So reducing depression and elevating mood using physical activity. Now, you don't have to write a prescription for that, even though I do have one here. And there's one on my Facebook, and I first released this prescription in '99. But some of the most important things to improve our health are not the expensive drugs, but there are things we can do for ourselves. And now there's a whole field of integrative medicine, and more young people are getting involved in. Things that we can do with people that don't involve necessarily medications, but can have a tremendous impact on their health. It improves mental acuity. When we were trying to get the schools to return to physical education K through 12, remember when we used to have physical education K through 12, and then one by one, school districts started saying we can't afford it. We need more math teachers. We can't afford to do physical education. And then in 2005, when I was chairman of the board of Action for Healthy Kids, something that we started after I left government, we put out a report summarizing all the data, and what it showed was that children who were physically active on a regular basis and ate breakfast performed better on standardized exams in reading and math, and also they were better disciplined in the schools. Now, it's interesting because many school districts had cut out physical activity to have more money to support teaching math and other things, but in many cases, one of the best things that could have happened would have been to really make sure that every child was engaged in regular physical. And some schools have now done it without hiring a physical education teacher. And they've done a good job as I've traveled throughout the country. But whatever it takes, we need to make sure that physical education is a part of it. Studies show that physical activity improves sleeping, and sleeping is a big problem in this country. Sleep disorders are growing. Studies show that physical activity reduces stress and anxiety. I'm not going to cover this. I'm going to stop so that if you have any questions. But the McKinley Model is something that we have really used at the Satcher Health Leadership Institute. It says that there are 3 levels of intervention. You can intervene downstream, as we do with patients and students individually. You can intervene in the community. A lot of communities don't have parks, they don't have walking trails. We need to change that. Or you can intervene upstream and change policies, right? That's upstream. There are a lot of policies that need to be changed. Well, at the Satcher Health Leadership Institute, we believe that in order to eliminate disparities in health, we need leaders who care enough, know enough, will do enough, and are persistent enough. Thank you.
Very inspirational talk. Thank you so much. Please, time for a couple questions.
Yes. Well, there are a few ways. We have a health policy fellowship, and that's for people who have finished their MD degree or their Ph.D. degree in a health-related field. We also have a community health leadership program for people who they may be at the master's degree level, or in some cases lower, but they are committed to community health leadership. Churches have sent people to go through that. Okay, I'm sorry. Yeah, churches have sent people. In fact, one of the first person to go through that program was the mayor of Tuskegee, and now we've had 10 mayors to go through that program. And our third program is the one I talked about, the Smart and Secure Children for Parents. So there are 3 different kinds of programs. Now, we're going to start another program soon for medical students to rotate 1 to 2 months. But that is an introduction to leadership as it relates to health equity. Okay.
You want to have a West Coast branch of your institute?
You got money for that?
We'll raise it. Dr. Pilot on campus.
Welcome, I'm Casey.
Oh my gosh, it's special.
Do you think there is any social or economic or cultural component to the predilection to prescribe opiates, or is it across the board reflexively? I mean, are there places where this is something that's routinely done for lack of considering something that's more wholesome?
Well, I certainly think that physicians and other health providers, nurses and others, come to the healthcare setting with different backgrounds and attitudes. And they behave differently because of that. Some of them have a tendency to want to work with people. Like Case Western, you probably know this, but they didn't have rotation in psychiatry. They had one in behavioral health. It included the psychiatrist. It was where I first saw my patient with paranoid schizophrenia. But the idea was that behavioral health is broader than just what psychiatrists do. And using that same philosophy, we have developed these integrated care programs, which, believe me, allows us to see many more patients with mental health problems. And also, I don't know if you're aware of this, but often when primary care providers refer mental health patients to the psychiatrists, they don't go. They don't go. In fact, over half of the time, they don't go. Ron forget Ron Glass. Ron Bailey who's a psychiatrist, talked about this the other day at the NMA. So yeah, I do. I think the background and experience of the provider determines how providers respond to a patient there in front of them needing that kind of intervention.
With all due respect about the Affordable Care Act, I've heard from some hospital workers that some insurances have been raising copays on people who are insured under the Affordable Care Act. And I just want to know, how can we keep it affordable for low NPS clients?
Well, you're right. I mean, that's one of the biggest problems now with the Affordable Care Act, is the increasing cost. Now, the Affordable Care Act had a very balanced plan as to how we were going to proceed and how we were going to implement prevention. And the substitutes, by the way, which the Supreme Court turned down, right? So there are a lot of things that were supposed to happen that have not happened because of the opposition in Congress to the Affordable Care Act. I mean, when you vote 68 times to repeal the Affordable Care Act, and then somebody's got to figure out a way to keep it going, that's an amazing challenge. So no, I think the Affordable Care Act has not been fully implemented, and if it were, prevention would be a major component of it. There was, I don't know, $10 billion was supposed to be in the budget in the first year for the prevention agenda in the CDC budget. And then it was supposed to go to $20 billion by 2015. Congress cut all of that out. And what they didn't cut out was they cut other things out of the department budget so they would not be able to do the prevention agenda. The prevention agenda said that every community has to provide access to safe places to be physically active, every child. And so we've never done that in this country before. Do you know that white men in England have a life expectancy that's white men who are college graduates in England, a life expectancy that's 5 years greater than white men in the United States who are college graduates? You know why? They invest more in prevention, health promotion than we do. We invest in treating people after they get sick. Those are big deals, if you haven't had that experience.
Okay, one more question, Kathy? Okay, we'll do Kathy then Norma. Quick question.
Really quickly. I'm just curious if you can comment on requiring medical schools to have more education for treating pain. So there was a study done about 5 years ago showing that the average amount of time in medical school, the 4 years of undergrad, was only 1 to 2 years for medical students, whereas veterinary medicine had like 12 times that. So I'm curious to know if anybody is implementing that.
That's a really critical point. And, you know, I don't know if it's been covered here today at all, but pain management is a critical part of all this. And if we are not training people to manage pain, then all they have in front of them is a prescription to write a drug. You know, and it's very difficult. So I know that not enough is being done to make sure that people learn how to treat pain. And they don't all have to be physicians, by the way. I know there was a student here talking about how he saw his role as a pharmacist, you know, in dealing with patients and their medication. Now, I think clearly pain control, pain management, and that's why mental health is so important, by the way, really critical to dealing with this issue. Because you can't drive it away with drugs. You've got to work with people in terms of how to manage pain. It is cognitive behavioral therapy, too, because you've got to, it's the way you think about your pain. Some people can stand much more pain than others, because pain is as much a part of the brain as it is a part of any other part of the body that might be hurting. It's a very important question. And the answer is no, not enough is being done. Who's the last?
Norma is the last. Quickly, please.
Thank you so much. I'm behavioral health work stuff. I know how important part of that. And thank you for mentioning the mental health, culture, race, and ethnicity. Can you talk a little bit about how that came to be? Does it happen?
Well, I'm not sure I can even remember. Well, we released the mental health report of 1999, and then people started to give us feedback. But if you read that first report, we have a major section dealing with culture, but we didn't go into the kind of depth that people wanted, so we decided to do another report, specifically mental health, culture, race, and ethnicity. People wanted us to look at that from the perspective of the fact that people have different cultures, different religions in terms of how they deal with their mental health. There are some religions that believe that, and I've told stories about this, and I don't have time here, but they attribute mental disorders to sin, to death, to the devil.